Hey everyone, welcome to the final lecture in the psych section. Talking about sedatives, hypnotics, and then a little bit about alcohol as well. The definition of a sedative hypnotic, kind of in a slang term, would be a downer, but they're in actuality used therapeutically for quite a bit of different indications. Specifically, the most common ones are listed here: anxiety, sleep, seizures, and sedation. Major properties are sedation, which can either have a calming effect or work as an anti-anxiety effect. So it's kind of like two properties there, and then also induction of sleep as a hypnotic agent. These are very commonly used medications. They have a high potential for abuse and commonly overdosed on as well. Start with benzodiazepines. So we've talked about these on and off for various things from muscle spasms to seizures, and now we'll get into them in a little bit more detail. But benzodiazepines are all controlled substances. They're all Schedule 4. And even though I think benzos are probably one of the most commonly abused medications on the market, they're still a Schedule 4, which actually puts them kind of low on the spectrum of controlled substances. The variety of effects depends on the agent. So I think of benzos working as on a spectrum. So there's sedation and anxiolytic effects, and they usually have some sort of a combination of those two things. They do work pretty quickly, so these are a nice fix for somebody who is suffering from something like an anxiety disorder with panic attack components. They can take a benzodiazepine to stop the attack from actually happening. Over long-term use, it's not recommended to continue them, but for short-term use, they do work pretty quickly, and they are effective as a sedative as well, and that will also, the onset of those effects are quite quick as well. Physical dependence is possible with benzodiazepines, and so the more you take them, the more you're going to need to get the same effect, and this can also cause a psychological addiction to the drug as well. Overall, if you use these in the short term or on an as-needed basis, they're relatively safe, but again, there's a chunk of the population that's going to require more and more, and they're going to develop that psychological addiction to them. And then there's also the risks that come with taking too many, and then the withdrawal risk, which we'll get into here in a few slides. Pharmacologically, these drugs work on the GABA receptor. I think I talked about this briefly during the anti-epileptic drug lectures, but the benzodiazepines will work on these specific channels. They're chloride channels that work to regulate how the brain processes excitatory responses and inhibitory responses. And so when benzodiazepines bind to a specific subsite, they potentiate the effects of GABA, which allows for a more inhibitory response overall, which counteracts any type of excitation going on in the body. Not completely, but to a certain degree. GABA is gamma-aminobutyric acid. It's an inhibitory neurotransmitter, and again, I kind of explained that already, but there's the other piece of it there and written out in case you want it. All the benzodiazepines are listed here. You'll see there's a variety of different doses, drugs, and elimination half-lives vary quite a bit across the drug, from really, really long-acting like diazepam and chlordiazepoxide, and then to shorter-acting like alprazolam and clonazepam. But even these drugs, clonazepam specifically, can be kind of considered a shorter-acting one, but it can last up to 50 hours in certain patients. Side effects, generally speaking, short-term low doses, you aren't going to see a whole lot of things other than just the acute phase type side effects, which are going to involve maybe some euphoria, sedation, shallow breathing, and possibly coordination issues. I kind of think of this like, having a few too many cocktails. The effects are very similar to what somebody would get with brief intoxication from alcohol. If somebody takes high doses, what you can see is paranoia, aggression, agitation, irritability, poor memory, and cognition. What happens is there's usually a sedative component to this as well, but you can actually induce a really interesting kind of counterintuitive irritation state where people actually get a little bit delirious and can actually act out and be aggressive on benzodiazepines. So when you think of them as a sedative, we usually don't give them to people with delirium because they can cause an inverse reaction. You might think, well, they're a sedative, that might be helpful, and you would think that, but in actual real life, that doesn't work out always as you plan, and these drugs are kind of notorious for causing increased aggression and irritability in patients who are already delirious. For people who take benzodiazepine long term, one of the problems is if you stop it, you can get significant rebound anxiety, and then as the drug gets less effective over time, it just isn't working at the same dose as it used to. And withdrawal risk is one of the biggest issues with long-term use of benzodiazepines because they're sort of notorious for causing seizures after people have been taking them for a long time, especially at high doses, and then if they stop them cold turkey, that's the biggest risk that comes with these medications. Overdose is going to cause heavy sedation, possibly respiratory depression, but it's difficult to shut down the breathing process completely with just a benzodiazepine. If people die from an overdose involving a benzodiazepine, it's usually because there's something else involved with it, like an opioid or alcohol or both, and that's normally what's going to lead to those increased compounded effects. By themselves, an overdose can be serious, but usually it's just significant sedation is all you really see. Metabolism is kind of interesting, and while they're all pretty much the same with respect to side effects and effects of the drug, there are three of them: lorazepam, oxazepam, and temazepam. So the lot drugs don't contain any active metabolites and have lower amounts of drug interactions, and they also aren't renally dose adjusted. So for patients with metabolic issues or kidney dysfunction, those are the preferred agents. For anti-anxiety purposes, probably the most common are the top two, alprazolam and clonazepam. They're probably the least sedating of the benzodiazepines, which is good because usually if you're treating anxiety, you aren't generally trying to sedate somebody. And the idea is maybe that if they're having a panic attack in public, they could take one without necessarily having to go find someplace to lay down for a while. You certainly probably wouldn't want them driving a car or anything like that after they took a benzodiazepine, but it is something to think about when it comes to using for short-acting anxiety purposes. Xanax or alprazolam is probably the least long-acting agent that we use regularly. Clonazepam, we saw the half-life of that from 18 to 50 hours. Actually, relatively long-acting medication, but it does seem to affect people differently. So for younger patients, probably going to metabolize it quite a bit quicker than an older patient. So that's something to think about too. When it comes to that range of half-life, you're probably seeing it affected by different metabolic variances within the age spectrum. So older patients are going to metabolize it much slower than a younger patient. Lorazepam is a more sedating option. It's a little bit longer acting than Xanax, kind of still considered short acting though. It's usually just not used as regularly for this purpose just because it is a significant sedative. And diazepam is even more sedating. It's very long acting and has some renally cleared active metabolites, so it metabolizes into more active forms, which is why it has that almost 100-hour half-life. And we use it for other things, but it's not as common as an anti-anxiety medication. So I mentioned SSRIs briefly when we were talking about depression, that we can also use these for generalized anxiety disorder, and SSRIs and the depression algorithm really applies directly to treating anxiety as well. However, remember, SSRIs take several weeks to work. So in the meantime, again, we do have the option to give somebody a benzodiazepine short-acting option so that they can take it while they get a panic attack while their SSRI dose is being titrated up. Usually alprazolam, I guess any of the ones on their slide, I should say, probably alprazolam, clonazepam, or preferred agents. It's really going to depend on the provider and what their history is going to be like. I think most people probably start with alprazolam or Xanax, but certainly the other two would be acceptable. I think it depends also on if you want to use it as a combination sleep aid. So if somebody's getting enough anxiety that they aren't sleeping very well, a drug like lorazepam might be advantageous because it is a little bit more sedating, and you would have those longer acting effects that would help a patient sleep and hopefully help their anxiety as well. However, as a daytime agent, not going to be very helpful. Now, driving, operating machinery, cognitive impairment are all things to consider. So, if somebody's taking one of these at work or something like that, know that they might not be highly functional or as functional as they normally would be during the rest of the day. As a sleep aid, you have tenazepam, which is Restoril. It's a long-acting benzodiazepine. It's not renally cleared. Remember, it's one of our lot drugs. You also have a drug called triazolam, which is halcyon, which is an interesting history that I have listed on this bullet point here. There was a case, and maybe a couple of cases related to halcyon. There was one famous one, at least, where a woman basically blamed halcyon for the murder of her husband. She said she was on the drug at the time and didn't have any memory of it whatsoever. I can't remember the outcome. You can Google it if you're interested. But it's an interesting case study in these medications because there is a lot of reported memory loss with them, and how that affects people and to what degree, and are they responsible for their actions while they're on the medication, is all really good questions and an interesting topic in and of itself. I don't see these two drugs used a ton. Temazepam occasionally. Triazolam I rarely ever see it used. Only people who are probably on triazolam anymore are people who have taken it for years, and it still works for them. They don't really want to try a different sleep medication, so that's what they're still on. Most of these drugs, benzodiazepines in general, have fallen out of favor for sleep aids in transition to a newer class of medications we'll talk about soon. But technically, any benzodiazepine is going to cause a slightly sedative and calming effect. So as a sleep aid, they could all be used for it theoretically. Benzodiazepine-like hypnotics. These are switching classes here to a drug class. I like to call them sleepers. Some people call them Z drugs. They are structurally dissimilar to benzodiazepines, but mechanistically they're very similar to the way they work. They're just more selective for a specific type of benzodiazepine receptor, but they still enhance GABA activity just in receptors that are more responsible for sleep-wake cycle than more generalized effects like a normal benzodiazepine would have. The drugs are listed here: zolpiclone, zolpidem, and S-zolpiclone. Everyone's probably familiar with Ambien as a drug. It's a pretty well-known medication. And between Ambien and Lunesta, those are probably the two that are prescribed the most. They're longer acting. Sonata was the first one out, and while it is effective, it's very short acting. So a lot of people will report that it doesn't really help them stay asleep long enough to be all that effective for them. But Ambien actually has longer duration, and then Lunesta is the longest acting. Lunesta is brand name only, so it might be a little bit more expensive than the other ones. Side effects, again, sedation and sleep activities are what people will see, which I'll talk about here in a second. Ambien CR is a controlled release formulation of Ambien. So here's just an interesting graph that compares taking regular 10 milligrams Ambien regular release with comparing your 12.5 milligram Ambien CR. Now the 12.5 is already a bit of a bigger dose, so you'd expect a larger area under the curve just because of that. But anyway, you'll notice this Ambien kind of has like a rocky peak. The regular release Ambien peaks faster, which is what we'd expect. But the controlled release has a more gradual approach to it, and it releases slower, and so you might get a little bit longer of a sleep duration. Now it depends on what your effective concentration is here, but you're probably looking at an hour or two more from the CR. So this has always kind of been illustrated as an example of something that's not all that beneficial. As sort of a joke, like Ambien CR really doesn't have a huge advantage over the immediate release. And when it was brand name, that was kind of a big deal. Now they're both generic, so whichever one you prescribe, I don't think it really matters. But I don't think there's strong clinical evidence to say that the CR is all that much better. But from a pharmacokinetic profile, it does look like it has a little bit longer of a half-life, a little bit longer duration, and it stays at a higher blood concentration longer than its immediate release component. So there is probably something to be said about people responding better to the CR. However, I don't know if that's necessarily a reason to prescribe it over the regular. I would probably still start with the regular, and then if they don't respond, maybe go to the CR after that. Because there is usually, even though the CR is generic now, there is probably a cost difference associated with that. All right, I found this on the internet a long time ago, and I just thought they were pretty funny, so I thought I'd throw them into the slides. This is somebody's cartoon called Ambien Walrus, and come with me on an adventure you'll never remember. And there's some little jokes here about what people do on Ambien. So this guy's saying, well, Ambien walrus, I guess I can't eat all the cookies in a 3-pound family pack. Myth busted. Let's go for a drive. And so this is funny, but also kind of true. Ambien is a notorious drug for, and all the Z drugs actually cause this. Basically, any benzodiazepine can have this effect, that people do things in their sleep that they don't remember. One of the most common things people do, there's walking and talking and stuff like that. That's normal even without drugs for some people. But doing things like cooking a meal or going and eating food or driving a car or calling somebody or sending text messages or things like that, doing things that usually most people during a regular sleep cycle aren't conscious enough to be able to coordinate to do something like that. Talking and walking around is one thing, but these people on Ambien some people on Ambien tend to have more significant experiences, and so obviously there's repercussions to cooking a meal during the middle of the night and using a stove or something like that could potentially be dangerous. And of course, driving a car could have disastrous consequences. So there's certainly things to consider. I think their incidence report of sleep activities with Ambien is around 20%. So it's pretty high. So 1 in 5 people will get some sort of significant sleep activity. Now, whether that's simply they get up in the middle of the night and go have a snack, or whether they hop in a car and drive, it's a pretty big spectrum of what's dangerous or what do we really care about. But certainly that might eliminate this class of drugs from being effective for certain patients if they are having significant sleep-related activities that they aren't in control of. Here's another one. Call your ex-girlfriends. Not now, Ambien. I'm trying to lose my car keys. So here he is misplacing something, and then again doing something I probably regret in the morning. So anyway, just some way to shed light on it. There's some more cartoons. Not all of them are safe for work, as we like to say. So if you want to Google them, you can probably find some other examples that are pretty funny. But the point is that this stuff does happen. And so it is something to consider from a clinical perspective when you're prescribing the medications. Alternative sleep drugs. So we haven't really talked about sleep as a module, and I didn't really want to because it fits nicely in here. And I just put this slide here so that we can revisit sleep and talk briefly about how do you treat sleep, because so many people report insomnia. It's really common, and a lot of people take something for sleep. So what are your options? Well, we just talked about Ambien. We talked about those short-acting benzodiazepines like tinazepam, but we have talked about some other ones as well. So antidepressants are probably the most popular choice because they're not habit-forming, they're not controlled substances, people tolerate them well, and they're all pretty cheap. So trazodone and mirtazapine are where I would personally start if you're prescribing something for sleep. Tricyclic antidepressants might be helpful as well. I'd probably reserve those for somebody with something else going on, like maybe neuropathic pain as well, or migraine prophylaxis or something like that. But certainly you could use them on their own. And the thing to think about with TCAs related to sleep is the dosing is usually quite a bit lower than what you'd use therapeutically as an antidepressant. Diphenhydramine, I don't generally recommend this as a sleep aid, but just because it's pretty anticholinergic, but it's over the counter and people have easy access to it. So a lot of people take it for sleep just because it's super easy to get. Melatonin. Now, is melatonin all that effective? Melatonin is probably the other really, really common agent that people take for sleep. And there is a prescription melatonin-related receptor targeting agent called Rameltian or Rosarem. I don't see this used very often at all. It's a super rare drug, so it leads me to believe that it's probably not all that effective since it's been around for quite a while now. And then you've got the Ambien-related drugs. And those are really the only medications out there for sleep. Sometimes you'll see people use, and this has gotten maybe a little bit newer, people use like second generation antipsychotics. See if I can get this. Especially Seroquel. Or quetiapine. At really low doses, quetiapine doesn't have a very substantial antipsychotic effect, but it does seem to have sort of an anxiolytic relaxation sedative effect. And so again, like I think I mentioned quetiapine's dosing range. People therapeutically, if they're taking it as an antipsychotic, are usually on several hundred milligrams a day, whereas as a sleep aid, you might take like 25 milligrams at night. So it's a pretty safe option, and it's one that's gotten a lot of popularity because it is a bit of a different class, has different effects. However, it's likely sedating because it's an anticholinergic medication. That's anyway kind of what I think about its mechanism. But So there is something to be considered there, that it might not be the best for everyone. However, it's gaining popularity and is a relatively popular choice as a sleep aid. And then there's this newer agent called suvorexant or Belsomra. I just gave it a little bullet point here because it's probably not going to gain a lot of popularity. It's an interesting mechanism. It's an orexin receptor antagonist. Orexin is apparently a neuropeptide signaling system that promotes wakefulness. The idea here is, instead of like every other drug putting you to sleep, this drug would actually keep you from waking up. Yeah, I think they thought that this was going to be a big blockbuster, and I don't know if it's really sold all that well. I just don't see a lot of patients on it. The interesting thing one of the things I find interesting about it is that you'd think that a drug that helps you stay asleep would couple well with a drug that's a sedative and puts you to sleep, but actually it's not recommended you take these really with anything else. Maybe with like an antidepressant or something, you could take it with that, but it's not recommended you take it with a drug like Ambien or temazepam. So as far as sleep goes, I don't know if I have a specific, again, I have kind of a personal order that I would go, and I'd start with an antidepressant. And then from there, I'd probably look at prescribing a drug like Ambien or one of the Z drugs as kind of my second choice there. But again, most people respond well to the Z drugs. Most people don't have sleep activity, so they are pretty safe medications. But the antidepressants as a whole are a little bit cleaner of a class in my opinion, but that's just my personal opinion. There's a lot of varying debates out there about sleep hygiene and things like that as well to consider too, and certainly there's lifestyle modifications that can help with sleep, but there are drugs, and then you're going to have varying opinions on which ones are going to be best to use first. Benzodiazepines for seizure use. We talked about this briefly, but these are the first line for stopping seizure activity acutely, not for maintenance therapy or long-term use. Lorazepam and diazepam and Versed or midazolam have all been used historically for this purpose. Lorazepam and diazepam are kind of interesting because basically anyone who comes into the ER is going to get lorazepam for a seizure, and the reason is it's a longer acting benzodiazepine, but it's not a longer acting from a half-life perspective. So I want to make that really clear because we already talked about that, right? Diazepam has a really long duration or a really long half-life. It doesn't mean its duration of activity is that long. So the difference is their lipophilicity. So diazepam is really lipophilic, meaning it gets into the central nervous system very quickly, but because of that, it also leaves quickly and re-equilibrates. So you can get seizure control fast with diazepam, but you can also get rebound seizures fast with diazepam too. And now eventually it'll have a more sustained effect, but it does take some time just because it distributes into all the fatty tissues and it kind of goes all over the body. Lorazepam is less lipophilic than diazepam, so it doesn't get into the central nervous system quite as fast, but once it does, it stays in there and it stops the seizure for a much more prolonged period of time. So for that reason, we do like lorazepam. That's kind of our standard medication for seizures acutely. Diazepam does come as a rectal formulation. These all come IV and PO, by the way, with the exception of Versed or midazolam doesn't come as a PO formulation. Midazolam is our IV sedative that we use commonly to keep people on continuous sedation, like in an ICU, but you can use it for a number of other things. It's really popular for induction during like pre-surgery as well. You can give it nasally as well, which is really nice for like pediatric indications or patients that have poor access. And if you're having like a tonic-clonic seizure, it might be very difficult to get an IV access to be able to give lorazepam or diazepam. So they formulated this diazepam rectal formulation, but administering a rectal formulation to somebody in public is a little bit tricky to do, to say the least. So a drug like Versed that you can give IN intranasally is really nice, and it actually works very fast when you give it intranasally, almost as fast as IV. The problem with intranasal is you are limited in the volume. You can basically do like up to a whole milliliter per nostril, and that's even exceeding the recommendations. For a kid, you're probably looking at like half a mil of product per nostril. Otherwise, the rest of it's just going to run down their throat or run out of their nose. You just can't absorb that much from the nasal mucosa. So that is one of the limitations. This is an example of how they give IN products. So it's basically like a little Lure Lock foam wedge atomizer that screws onto a syringe. So you'd actually pull out the IV product from a vial, screw on your nasal atomizer adapter, and then you'd spray it into their nose, and it kind of pushes it through as a fine mist, and then it can get absorbed that way. And again, it does work quite quickly if you do that method. For alcohol withdrawal, benzodiazepines have a big role to play. And again, our major risk is seizures, not only for benzodiazepine withdrawal, but also for alcohol withdrawal. And so benzos can help prevent that. There's a lot of protocols out there. If you want to Google these more and read about them, there's one called the MINDS and one called CIWA. But basically, they're kind of the same concept. And you really just assess a category of symptoms. And from there, you say, okay, these patients have this many symptoms, which equates to this score, meaning they get this much benzodiazepine. And that's really all there is to it. And then you repeat that every so often until they start to get off the protocol. But that's the way we treat inpatient, anyway, alcohol withdrawal. Lorazepam and diazepam are the two that are used in the MINDS and CIWA protocol. Some people will advocate for an older drug called chlordiazepoxide, or Librium, which is considered to be the longest acting. However, I don't think it's really that much longer acting than diazepam. I don't think it has a huge advantage over it, which is why we probably don't really use it anymore. But some people will say that for withdrawal, this was the gold standard, I think, for quite a while. It's a very long-acting hepatic metabolites. And so the longer acting drug you give, like we use diazepam for our withdrawal protocol, the idea is that you get more drug in the system that's kind of buffer itself throughout the whole withdrawal period. Whereas if you're giving bumps of lorazepam all the time, you might have to be playing more catch up than you'd want to. Whereas the diazepam, the active metabolites, will stick around in the system more often. Elderly adults are much more sensitive to the effects of benzos. Until last year. This is probably an old statement. I'll just say until recently. I can't remember when the year was. But for quite a while, Medicare didn't even cover any type of benzodiazepine. Now they actually do pay for some for certain conditions. So that was one thing they just said, we don't think there's any reason for the elderly to get these. There are occasionally indications for them. So dose is probably the biggest concern, making sure you're dosing them lower than you would for a younger adult. Overuse is an issue, as it would be for any age group. I've seen lots of seemingly, they kind of think of them as the stereotypical little old lady that is on 1 milligram TID of Xanax, and that's kind of a lot actually. Maybe like a quarter milligram TID of Xanax or something like that every single day. And they've been taking that, they've tried to wean them off, and it's really difficult to get them off that last little bit of Xanax. And so that's a really common thing. So if you get these patients on these drugs, it can be really hard to get them off at one point. And that applies to any adult, but the elderly seem to be more susceptible, even to small doses, to finally getting rid of the medication if you're trying to wean them off of it completely. We've talked about the delirium dementia component a little bit already, so I'm not really going to go back into that. Other than that, remember our three big ones for delirium: benzos, anticholinergic meds, and opioids. Those are the three. Always remember when it comes to delirium, it's almost always going to be one of those three as a culprit if somebody's delirious in an inpatient or an outpatient or like a long-term care setting or something like that. All right, benzo withdrawal. So we talked about this, seizures being the big one that can cause somebody to be, from uncomfortable and unpleasant to an emergency. Tachycardia, some increases in heart rate, usually due to the rebound anxiety somebody's getting, which can go in conjunction with panic attacks. Tremors, perception changes. People might experience weight loss, anorexia. But again, the big one is going to be seizures. Reversal. We do have a reversal agent for benzodiazepines. It's a little bit controversial on how you use this drug, so I'm going to go into this criteria here. It's pretty straightforward, I think, but I think people get nervous whenever you mention flumazenil. Romazicon is the brand name of this. It's a competitive benzodiazepine receptor antagonist. So it's basically like the Narcan for benzos. Think about it that way. It doesn't really do anything to somebody who doesn't have benzodiazepines on board. You want to start with low doses of the medication. The risk is precipitating a withdrawal seizure. So when you would use this, there's some key indications for this drug. Enhanced recovery from short-term procedural sedation. So if somebody got a little bit of midazolam during surgery and you want to reverse that to help bring them back out of their medically induced sedation, then that's probably fine because that patient isn't taking benzos any other time. So there's no real risk of a seizure if they've only been on the drug for a few hours. If somebody is giving small doses, of a benzodiazepine. Like, let's say somebody came in and they're maybe an older person experiencing nausea and vomiting. You tried ondansetron, you tried prochlorperazine. Those two didn't work, so you gave a little bit of Ativan or lorazepam because the person was maybe a little anxious too. Perfectly normal clinical scenario. However, some people will be a little bit more sensitive to it. Let's say the patient's getting really really sedated on it. They are not responding to commands. They might start to be having shallow breathing. O2 sats might be going down. That's a case where a little bit of flumazenol can be very helpful. And again, this is a patient who would probably be benzodiazepine naive. That's the ideal situation because there's really no risk in with a withdrawal seizure if somebody is just on one dose, or again just taking it for a procedure. It doesn't really make a difference. But it's those chronic users that's the key. Also, one-time overdoses. This is probably the most controversial because if you did have somebody who overdosed on benzos, the question is, do you really know if they were a one-time overdose or not? And the reason I say that is because what if you had somebody who said they got benzodiazepines from a friend, but they'd actually been taking them for weeks and getting them from the street. And people, you don't always have a history during an overdose, so that can be really tricky. You'd have to be very sure that that patient just recently got a supply of benzodiazepine and overdosed on it directly and didn't take it for days, weeks, months beforehand. And so that's when you go into when not to use. Chronic benzodiazepine users, if you're over sedated after being treated with a benzodiazepine for a seizure, those are the two big ones. If you gave somebody a romazicon for being over sedated, then you're going to end up putting them back into their seizure because you just worked against the medication that's helping suppress their seizure. So then you just manage the sedation in this case. And then for the chronic users, you want to figure out a way to wean them off of it. So there's lots of different strategies for that. And I think I might go into those soon. And what do you know? There's a slide right here. So tapering and stopping benzodiazepines, there's a bunch of different methods out there. Probably the most common one is the same agent switch, where let's say somebody's taking a bunch of different benzos or the same benzo. You calculate their total daily dose, figure it out, and then follow a schedule where you can taper them down over a period of time. That's pretty straightforward. It's easy. There's not really a lot of complicated math to it. You just kind of pick. There's not really even much in the way of recommendations. It's like, when do you drop the dose? After a week, 2 weeks? Doesn't really matter particularly, but it depends on where they're going to be. If they're going to be in the hospital, you can do it much more aggressively. If they're going to be outpatient, you want a more gradual taper system. If somebody is on large amounts of benzodiazepines, usually what we do is dose reduce by 40% and drop by 10% per day. This is the hospital method, so it's an aggressive one where you can get somebody off of benzodiazepine fairly quickly, but it's been shown to be pretty effective. However, you do have that withdrawal seizure risk. And then, whether you use the same agent or you consolidate to a different agent is totally up to you. So a lot of times we'll consolidate to diazepam. Some people will do Librium, which is chlordiazepoxide. But diazepam is a pretty common one because it's a longer acting agent. So maybe you have somebody who's taking a ton of Xanax, they're maybe 6-10 milligrams worth a day or something like that, and you want to switch them to diazepam. You figure out an equivalent dose, which can be tricky, but there are some recommendations out there. I'm not going to go into them because it's not super sound science. But anyway, you switch them to the equivalent dose of diazepam, then you give that to them as a once daily thing and taper them off of that over time. Phenobarbital has also been used as a tapering option, but that would be sort of like a last line. I don't think it's rare to see that used. I'll just leave it at that. Other agents, like, do anti-epileptic drugs help? It's a great thought and question, but there's not really a lot of evidence that says they are worth doing. But some people might say there are some small trials that show that carbamazepine and gabapentin have played a role in being synergistic as an adjunct for benzodiazepine tapering, and can also help prevent the seizure component of it as well. But it's not done all the time. Buspirone or Buspar isn't a benzo at all. It's actually more of a serotonin drug, and it also has some dopamine antagonism. It's indicated for generalized anxiety disorder. I didn't really have a good other spot for it because it's not for depression. It's not an SSRI, but it's used, I don't know, it's used kind of all over the place now. So maybe I probably should just include this in the depression lecture. But anyway, here it is. This is, again, it's basically just a serotonin agent. It's not an SSRI, but it acts on the serotonin system. Takes 2 to 6 weeks to work, usually dosed 2 to 3 times daily. I just want you to know that. It's a pretty common mental health med, so I wanted to make sure it was slotted in here. It was originally designed as a maintenance med for general anxiety disorder, but again, it's used as for depression and other augmentation uses as well. All right, barbiturates. Barbiturates are sort of an antiquated class of medications. They aren't used all that commonly anymore. They work very similarly to benzos, but I think of them as a more aggressive formulation of it. They bind to the GABA receptor at a different site, but they seem to have a more potent and pronounced effect. Phenobarbital is the drug that probably is most commonly used in the class still. It's a sedative hypnotic. It also is anticonvulsive. It's sort of a far down the line option for all of those things. It's not going to be your first line for any of those, but it might be used for some of them. It's going to be really rare to see this used unless you work at in a neuro ICU. Every once in a while we have a patient who has irretractable seizures and we need to suppress them on something and sedate them as well. And so every once in a while we do not necessarily a phenobarb drip, but probably more like a pentobarbital drip, which is a similar medication. Anyway, these medications cause more profound side effects than their benzodiazepine cousins, and you get more hemodynamic issues, which is the more complicated problem with using them in addition to respiratory depression. So they're quite a bit more deadly when used in excess or in overdose situations. They are Schedule 4, just like a benzodiazepine, in case you're curious. There's a lot of other ones on the market. Sodium thiopental I just put on here because it is part of the lethal injection 3-drug cocktail in addition to potassium chloride, and I believe, I can't remember what paralytic they use, rocuronium or succinylcholine, one of the two. Anyway, we'll talk about that more, not the lethal injection, but paralytics more in emergency medicine. Pentobarb is a shorter acting, higher potency one that we use for more of a direct IV sedative. It's associated with animal euthanasia. And I think Marilyn Monroe actually abused or overdosed on this, which I think is interesting. If you look back at times and what people took as drugs, I don't know if anybody really uses pentobarbital recreationally anymore, but certainly at one point it was. Butalbital is a short-acting, low-potency one that was combined with acetaminophen and caffeine as an option for migraine treatment. Usually it just causes probably higher risk for rebound headaches, and it's more addictive than other medications, so it's probably not, I don't recommend using it if you could avoid it. There's other barbitals out there, but I don't really care any of them. Is that I did get this question, I can't remember if it was last year or the year before, but somebody was asking me about Quaaludes. I don't remember why. I think it was is either like, maybe this was a couple of years ago, but I think in the Wolf of Wall Street they abuse Quaaludes, and then there's in True Detective, the show with Matthew McConaughey, there's some references to Quaaludes as well. Quaaludes are a barbiturate type of drug, and they were a class of, it's kind of a subclass of barbiturates that were prescribed, back I think in like the 70s. It's been a while since they've been on the market, but there might be synthetic versions or kind of residual versions of them, but they are barbiturates. In case you're curious what Quaaludes were. Okay, and alcohol. Last few slides on alcohol. I've got a bunch of social stuff in here just for fun. Alcohol is probably the most ancient of the drugs of abuse out there. I do have even a Bible reference from Genesis here, which talks about Noah becoming drunk after drinking wine. So certainly, there's my Bible reference for the year, by the way. You picked that one? Yes. So anyway, archaeological evidence dating way back. People have been fermenting various things to make alcohol since basically man existed. So it's got a lot of history and culture associated with alcohol, and different cultures react differently to alcohol. Obviously, some religions restrict it or ban it completely in their practice, and other ones are much more tolerant of it. So it is kind of an interesting thing throughout the country and throughout the world who consumes most alcohol. And here we are in the upper Midwest. We had all this good data. We had all this good data for Minnesota, and then the upper Midwesters, apparently we like our booze. Who knows? It's those cold winters. That's what I blame it on. You need a little whiskey to warm yourself up. So and then consumption based on per capita. You can see obviously European countries having much higher consumptions than, for example, Middle Eastern countries, which again makes perfect sense, right? Based on cultural and religious influences. The chemistry of alcohol, or ethanol, is the compound in alcohol which causes the drug effects. It's a very simple molecule. It's interesting. So in case you want a little review here, yeast and sugar and water gives you carbon dioxide and ethanol. Most alcoholic beverages usually get about 10 to 15%. Of course, you can distill to concentrate the ethanol like you do for spirits. And then there's some places you can like freeze off water to concentrate. You can, like Sam Adams Utopia. I did the Sam Adams tour a long time ago, and they talked about their Utopia's beer, which is a 29% ABV, and they actually used a mutated yeast strain that's genetically engineered to tolerate higher alcohols to make that particular product that high. And then they barrel age and stuff like that. Anyway, so just some fun facts here. Obviously not on the exam, but anyway, there's a lot of products that have this in them. It's all basically the same thing when it comes down to it. The compound is always ethanol unless there's some contaminant in there, like in moonshine or something, and somebody's making it in their basement and it's got methanol in it, and then you're going to maybe poison yourself, but even more so than with ethanol. So anyway, avoid that. But for commercial products, you're getting the same thing regardless if it's beer, wine, or some kind of spirit. Interestingly enough, despite ubiquitous use and historical use, we don't really fully understand ethanol and how it affects the body. And it's because it probably affects so many different systems and it does so many different things that it's kind of hard to track. We know for sure it has effects on GABA receptors, and it's probably got similar effects to benzodiazepines. Because why? Well, people respond really similarly, very similar withdrawal effects, very similar overdose effects, and similar tolerance effects too. So it's got some of those aspects to it. Now it does other things as well. Specifically, some people say it has an NMDA type receptor antagonism, which causes a dissociation-like complex at higher doses, increase in dopamine levels, which adds to maybe its addictive potential. Ethanol is very rapidly absorbed. If you drink like a large amount of ethanol, we've all probably drank an alcoholic beverage on a relatively empty stomach at one point in our life. Not judging, but just saying it happens every once in a while. You mow the lawn, come in, have that cold beer, and the alcohol, maybe you feel the effects of it, even if you're drinking a very light beer or something like that. So it is a very fast absorption. It also is metabolized relatively quickly, and your liver is equipped to metabolize a decent amount of alcohol before the processes kind of go haywire. So what happens is ethanol gets metabolized into acetaldehyde via alcohol dehydrogenases, and then aldehyde dehydrogenase metabolizes acetaldehyde into acetate, which can be removed by the kidneys at that point. All right, so what happens? Why do people get hungover and sick when they drink too much? Well, the aldehyde dehydrogenase eventually gets maxed out. Remember, your liver is a pretty resilient organ. It can metabolize a lot of alcohol, but at some point you just run out of your enzymes and you don't have any more. So you get too much alcohol in the body to fully metabolize, so you get a buildup of the acetaldehyde intermediate because, just go back to this really quick, this one, the aldehyde dehydrogenase, gets worn out much quicker than the alcohol dehydrogenase. So alcohol dehydrogenase can keep trucking for a while after the aldehyde. So you get this acetaldehyde intermediate, which causes the toxic effects and the headaches, the nausea. The other part of that is dehydration. And alcohol, ethanol itself, actually is an inhibitor of antidiuretic hormone, which causes an increase in diuresis, which can cause electrolyte imbalances and dehydration. So those two combined things, having one, a toxic intermediate in your body, and two, a concentration of that because you're dehydrated on top of it, is sort of a double whammy as far as the effects it has on the body. Also, interestingly enough, there's likely some immune system related effects. However, we don't really know, but there's likely some enhancement of inflammatory cytokines during the process of excess alcohol intake. So NSAIDs tend to work pretty well for hangover treatment, and there's a reason for that. Some beverages may contain other chemicals. So whether the product is a pure alcohol or not doesn't necessarily matter. If you're drinking a ton of ethanol, you're going to get some probably negative effects regardless. However, interestingly enough, I just put this in there because people actually have done studies on this, that people who drink darker liquor actually tend to have a worse hangover. So let's say you drink whiskey, for example, that's got a brown coloration to it because it's aged in oak barrels usually, versus like vodka, which isn't aged at all, it's just distilled. People actually report that on average, again, based on scientific evidence, that the darker liquors cause worse hangovers than the lighter and that's maybe because the effects of the aging of the product add extra chemicals and compounds to it versus a simple distillation doesn't. But again, you're getting into science that we don't really know that well. We just have social experimentation to figure that out, right? Okay, so acute alcohol effects, what happens to people when they drink alcohol? You have a concentration in exhaled air is about 0.05% of blood alcohol content. And broken down here, what you're looking at. So 0.1, or sorry, 0.1 would be decent. 0.01 to 0.03, usually no one's going to notice an effect with this. It's just not enough concentration in the blood. Now, somebody might end up at this or higher after a small amount because their body can't process it or they aren't used to it or whatever. But the point is, at this particular BAC, most people aren't going to notice any effects. 0.03 to 0.05, mild euphoria, maybe a little bit relaxing, a little talkative, decreased inhibition, impaired concentration. This is where you get to borderline, probably can't drive, and then once you get into 0.06 to 0.1, that's when you get these impaired reasonings, the depth perception. If you're ever wondering where they cut this off, that's the big one, and the peripheral vision as well, just making it much more difficult to drive at that point. And so that's why 0.08 is the limit for that particular one. Once you go on there, it gets worse and worse and worse as far as what type of impairment you get. So 0.1 to 0.3, emotional swings, loss of understanding, memory blackouts, impaired reflexes, staggered walking, slurred speech, sexual dysfunction. 0.3 to 0.5%. You have severe CNS depression, unconsciousness, lack of behavior, impaired breathing, and then 0.5 you're looking at the average person dying from that. But if you have had chronic alcohol intoxication for several years of your life, 0.5 might not be all that bad for you. I've definitely seen people at 0.5, 0.6 that are relatively functional for all things considered. They aren't dead and they aren't completely passed out, which is impressive to have that much alcohol in your system. So your body can build up that tolerance to it. It just for the normal person who's maybe a moderate drinker or a non-drinker, that's going to be devastating for them. Okay, number of drinks. This is just interesting in case you're curious as to like what counts a drink and what has where the cutoff is depending on your weight. So if you're 175-pound male, and well, I guess this doesn't matter. This isn't male versus female, but usually if you're like, well, what's the difference? Why does it say men can have more drinks than women? Usually just weight is the end game there. So more weight, you can tolerate more alcohol usually. As a self-medication, alcohol is certainly common as a self-care. A lot of people, how many times have you heard somebody say, I need a drink, or you may like jokingly speaking, maybe saying like this day makes me want to drink, or Chad's pharmacology lectures make me want to go have a beer. Maybe now that you're at home, you can have a beer. Well, I don't know if I can say this, but anyway, so plenty of people kind of joke about this, but certainly it's not really a joking matter for a lot of people out there, because alcohol is a major issue and it causes a lot of hospitalizations, causes a lot of people to be not as functional in society and life and in their relationships as they'd want to be. Alcohol, a lot of people will take it to sleep. They drink enough, they kind of pass out. It's effective from a sedative perspective, but it does actually inhibit sleep by suppressing. Sorry, it inhibits the REM cycle. So the sleep you get is basically not restorative sleep that your body needs. Depression and anxiety effects are temporary at best, and over time, alcohol has been shown to actually worsen mental health disorders. And one of the big deals with this as well is if, let's say, you have a patient who you're prescribing or trying to treat their depression with medications like SSRIs, and they're drinking at the same time, and you don't know about that, then that might be masking some of the effects the drugs can have. So you don't really know if the drug's not effective because the person wasn't taking it, or that doesn't work for them, or sure enough, you find out they've been drinking. That's actually really common, that people will continue to self-medicate while they're on a different medication, and then that it's very difficult to assess that and try and figure out a treatment plan when you have alcohol as a confounding variable. Acute intoxication, anything from nausea and vomiting to reckless and sometimes silly but inappropriate behavior to things that can be, consequentially fatal, like car accidents. So lots of problematic consequences associated with alcohol use. Toxicity chronically. GI-related toxicity over time, you're going to get gastritis and mucosal damage. Ethanol itself causes this, plus the frequent emesis and reflux from vomiting. You may impair your nutritional absorption, prevent adequate nutritional intake, either because you're sick, you feel sick, or you don't want to take it, or you're just drinking all the time. Hepatic related effects, certainly we all know that the toxic effects of alcohol affect the liver. Essentially, that aldehyde buildup over time causes excessive oxidative stress and cellular necrosis. So the liver is a very resilient organ. It takes a lot to kill the liver. So this isn't something you can do quickly. It's not an acute effect, but over years or decades of drinking, your liver will eventually not be able to respond, and then you get to the point where you need a transplant because your liver simply can't respond to the processing of the alcohol anymore. And then there's obviously lots of other downstream effects of not having a functional liver as well. Neurologic related effects, polyneuritis, tremors, seizures, loss of brain mass are shown with chronic alcohol use, long-term alcohol use. Something called Wernicke's encephalopathy, which can lead to a symptom called Korsakov's psychosis. Wernicke's is initial brain damage from swelling due to vitamin B1 deficiency. So people, we haven't talked about supplements yet, but thiamine or vitamin B1 is the first vitamin that your body will lose when you don't have any nutritional intake. Basically, you have the lowest amount of stores of it. So if you aren't eating a correct diet, you're going to see more effects of that one initially. So that's why people who have alcoholism or are malnourished, thiamine is one of the drugs we give people right away. Confusion, loss of muscle coordination, and vision changes are seen with Wernicke's. Ultimately, you can get permanent damage from this encephalopathy, which is where Korsakov's psychosis comes into play, which can involve things that almost look like schizophrenia, like hallucinations, loss of memory, confabulation, inability to form new memories, which is basically permanent at that point. And at that point, it's due to direct brain damage. You don't really have drugs that can treat that. You can give antipsychotics, things like that, but the odds of them doing much, it's pretty slim. Cardiovascular related, hypertension, cardiomyopathy, CHF risk, arrhythmias, and stroke risk all goes up. Reproductive effects, impotence, infertility. Infertility actually in both males and females goes quite a bit up for people who drink heavy amounts regularly. And then, of course, if you do get pregnant, the teratogenicity effects of fetal alcohol syndrome, causing growth retardation, poor coordination, muscle growth, and organ dysfunction. Chronic alcoholism, some more things to mention briefly. There's psychological components, so there's cravings, loss of self-control, tolerance, you want to drink more and more to feel normal. Physical dependence, high ethanol consumption means high risk for withdrawal. We'll talk about withdrawal in a second. Treatment for chronic alcoholism, we talked about benzodiazepines. For the possible psych-related symptoms, haloperidol is usually used for people who are having hallucinations or psychosis-related experiences with their either withdrawal or the alcohol they're drinking. Long-term treatment, naltrexone actually, as a long-term agent, has been shown to be somewhat helpful. And there's a drug called disulfiram, which is antabuse. What antabuse does is it inhibits aldehyde dehydrogenase. So if you take a drink of alcohol, you're going to feel quite sick fairly quickly because your body can't metabolize it at all. And so the idea is that it causes sort of a psychological deterrent effect because you don't want to drink because you will feel sick if you even have a drink. But that also requires you to actually take the antabuse, which you have to take it like 3 times a day. So not the most effective, but it's an option that does work for some people. Naltrexone comes as a long-acting intramuscular injection, so that's a little bit easier from a compliance perspective. And you might be thinking, well, why does that work for alcoholism? And I think I talked about this back in January, but it does. Why, I don't know. I think there's probably some roundabout mechanism there that works, that drinking alcohol and stimulating the dopamine response has something to do with mu receptors as well. So if you block those, you kind of block that part of the pleasurable reward pathway, and that can help with addiction, specifically with alcoholism here. For stopping for people who are chronic alcohol ingesters, if you stop it, you're going to have some minor symptoms right away. Within a couple of days, you're going to start going into I can't say the word, hallucinosis. I don't actually know if I've ever heard that word before. But anyway, you might have hallucinations, visual, auditory, tactile, and then withdrawal seizures can happen too. And that's usually going to be seen around day 2 of stopping drinking. Delirium tremens, agitation, hallucinations, disorientation, tachycardia. There's a bunch of stuff that's sort of like the peak effects you might see with somebody who's been chronically ingesting alcohol and stopping drinking it. This I'm not going to test you on. I put this on here just as an example of how you might assess somebody for inpatient ethanol withdrawal. So I mentioned this during benzos briefly, but really it's the nurse who would go through this with the patient. So they'd assess, okay, your anxiety is a 2, you're sweaty a little bit, not a lot, you get a 2, I don't know. So you assign scores to this and kind of go through the whole thing. And then you would, oops, I go through, yep, here you go. So then you'd give a certain amount. So your total score, and then it's your assessment here and how often you do it. How often you reassess, how much drug you give would all come from that score. So there's that criteria that's somewhat objective, somewhat subjective based on the nurse, and then you end up with giving drugs because of the score. And again, we can use lorazepam or diazepam. This is an example with lorazepam, and this is from our old, we used to use the CWA protocol, I think, and now we use the MINDS. Anyway, I get those mixed up. But anyway, we use the diazepam one now. But again, same concept. So the lorazepam here is all built out to how much you would give based on the scores, and then when you reassess. And so that's really it. As far as testable stuff goes, I'm not going to test you on really much of the alcohol stuff. What I'd like you to know is some of the effects of alcohol withdrawal. I'd like you to know the couple drugs you can use to treat long-term, so naltrexone and disulfiram. And other than that, just kind of the general effects pharmacologically of ethanol ingestion, and that's really it. I don't care about the social stuff, and I don't care about you knowing specifically how to treat withdrawal and go through this type of an algorithm. Again, I would want you to know the benzo component of that to know that that's a use of it, but you don't have to know the specifics of it, if that makes sense. All right, that's it for psych. We'll do an exam review shortly, and I'll maybe see you guys sometime.